screen visible?
No, sir. Yeah.
Screen is not visible right now?
No, sir.
Okay, just a minute. Just a second. Is it now visible?
Yes, sir.
Okay. Yeah. Good afternoon, everyone. First of all, I'd just like to welcome Dr. Sanjeev Yadav, sir. Thank you, sir, for being such support for me and helping me to present this presentation on a very important topic of non-invasive ventilation. Yeah. So I would be moving further with these slides. Yeah. So I think there is some disturbance in the audio. Am I audible right now? Hello.
Yes, sir, you are audible.
Yeah. Okay. I'm moving further then. Yeah.
Okay.
So a very warm welcome to all the nurses, all the staff, all my colleagues and my seniors. So the topic for today is a non-invasive ventilation, जो हम लोग normally ICU wards और कहीं भी हम लोग use कर सकते हैं. And it is a very important topic to be taught to nurses because we all have a chain. It depends on the skills of the clinician, patient selection, as well as the equipment selection. And this will help to decide that whether we are giving NIV success or not. So a doctor cannot work without the help of a nursing staff. So it's very important so that nursing staff and the doctors in the ICU, in the emergency, OTs, or as well as in the wards should work together for a better patient outcome. So now moving further, what is non-invasive ventilation mean? Non-invasive ventilation का मतलब administration of ventilatory support. Hello. Yeah, it is the administration of ventilatory support without using an invasive airway. मतलब बिना कोई ट्यूब डाले, बिना कोई ट्रकिया में कोई ऐसी चीज डाले जिससे वेंटिलेशन हम करते हैं, उसके बिना हेल्प के जो हम लोग वेंटिलेशन प्रिपेयर करते हैं, दैट इज अ नॉन इन्वेजिव वेंटिलेशन.
Dr. Shushank, please.
Hello. Sir, you are on mute. Start mute.
Yeah, now am I audible?
Yes, sir.
Yes, sir.
Yeah.
Yeah. Okay.
Oh, okay, Dr. Shushank. Yeah.
Okay. Just a minute, sir. Okay, now the screen is visible. Hello.
Yes, okay, Dr. Shishant. Continue.
Okay, sir. Okay. So, जैसे कि I was talking about, non-invasive ventilation is a type of ventilation in which we don't require an endotracheal airway या कोई भी ऐसी ट्यूब जो हमको ट्रकिया में ना डालनी पड़े, उसके बिना जो हम वेंटिलेट कर पाएं, that is known as type of mechanical ventilation, non-invasive. So now, non-invasive ventilation के what we all need is a ventilator unit, a tubing, an exhalation port, and an interface. Interface means just a type of mask. It can be nasal, it can be oronasal, it can be helmet. So there are different types of masks for non-invasive ventilation, and we will talk about it in the further slides. उसके आगे जब बढ़ते हैं तो just to small introduction about what is the history of mechanical ventilation. पहले जो वेंटिलेट हम करते थे, that was a negative pressure devices, and उनमें हमको पीप नहीं देना पड़ता था. There was large devices, large ventilators were used, and there was significant leakage, but not high morbidity and mortality of the patients, and they were known as the tank shock. उसके बाद as we move further, we came to positive pressure ventilation. Now जो हम लोग यूज करते हैं, that is a positive pressure ventilation which have better results as compared to negative pressure. And in this, when we come into non-invasive positive pressure ventilation, this is the this was first used in 1980s by the help of mask and the nasal prongs for obstructive sleep apnea. And the major indication from where the non-invasive ventilation came into existence, जहां से हमने non-invasive ventilation को यूज करना शुरू किया, that was because of obstructive sleep apnea. Now, what is respiratory failure? हमको ventilate कब करना होता है पेशेंट को? There are two types of respiratory failures. One is hypoxemic, second is hypercapnic. So type 1 is hypoxemic, जिसमें ऑक्सीजन की कमी हो. Carbon dioxide is almost normal, and in this arterial oxygen जो हम लोग नापते हैं, that is less than 60 mmHg, and FiO2 जो हम लोग दे रहे हैं is more than 50%. So at that point of time, when we talk about non-invasive, अगर हम उस टाइम सोचेंगे, so we can go for a CPAP mode or a BiPAP mode. सेकेंड इज हाइपरकैप्निक फेलियर, जिसमें पेशेंट को वेंटिलेटरी फेलियर हो रहा है. एक ऑक्सीजन पंप का फेलियर हो गया टाइप 1, और टाइप 2 जिसमें वेंटिलेटरी फेलियर है. पेशेंट ऑक्सीजन ले तो पा रहा है लेकिन कार्बन डाइऑक्साइड बाहर निकाल नहीं पा रहा. सो देयरफॉर आर्टेरियल CO2 in here becomes more than 50 and pH becomes less than 7.25. So a type of this is respiratory acidosis, and इसमें the best mode of ventilation in the starting before the invasive ventilation is the BiPAP mode or a non-invasive ventilation BiPAP mode. Now, where to use NIV? NIV cannot be used in every patient. So now, जैसे मैंने फर्स्ट स्लाइड में बताया था कि NIV की सक्सेस के लिए तीन चीजें इंपॉर्टेंट है. सबसे पहले पेशेंट सिलेक्शन, देन equipment selection, and then the clinical skills. Or clinical skills not only depends on doctors but also the nursing staff. Nursing staff is around the patient 24 hours. So जो भी चीजें पहले होंगी, पेशेंट की डिटेरियोरेशन को पहचानना, पेशेंट रिस्पॉन्ड कर रहा है कि नहीं, that is the part and parcel of a nursing bedside nurses, and therefore it is very important to teach them about non-invasive ventilation. So now where to use? Well, first is the acute respiratory failure. One will be, as I told, hypercapnic acute respiratory failure. So इसमें क्या-क्या हो सकता है? Acute exacerbation of COPD, post extubation, and of obesity hyperventilation. These are the major three indications for using of NIVs. Now इसके अलावा भी weaning difficulties, जिसमें पेशेंट का CO2 बढ़ रहा है, respiration rate अच्छा नहीं है, tachypnea है पेशेंट को, chest wall deformities, cystic fibrosis, neuromuscular diseases, and status asthmaticus. Second indication is hypoxemic acute respiratory failure. पेशेंट को लंग्स में कोई दिक्कत ऐसी आ रही है कि वो अंदर से ऑक्सीजन को या तो ले नहीं पा रहा, या लेने के बाद यूटिलाइज नहीं कर पा रहा, या फिर ऑक्सीजन का डिफ्यूजन जो होना चाहिए एल्वियोलाई और कैपिलरीज के बीच में वो नहीं हो पा रहा. तो इसका मेजर कॉज कैन बी अ कार्डियोजेनिक पल्मोनरी एडिमा, कम्युनिटी एक्वायर्ड निमोनिया, कंसोलिडेशन होना लंग का, ARDS, and weaning difficulties. Then again, as I told, there are two types of major non-invasive ventilation: negative pressure and positive pressure. Negative pressure we don't use nowadays, so positive pressure ventilation. Why to use NIV? Now हमारे पास दो चीजें हैं. हमारे पास invasive के लिए we are all trained in using endotracheal tubes, laryngeal mask airways, oral airways, nasal airways. Any device which can be used, which has to be inserted, is an invasive ventilation. And उसके अलावा जो हम अगर किसी मास्क का या nasal mask या ओरोनेजल मास्क का यूज करते हैं विदाउट पुटिंग एनीथिंग इन दी ओरोनेजल कैविटी, दैट इज अ नॉन इन्वेजिव वेंटिलेशन. एंड क्यों यूज करना चाहिए? फर्स्ट ऑफ ऑल, एज द नेम सजेस्ट, जैसे नाम बताता है, नॉन इन्वेजिवनेस. हम कोई भी चीज अंदर डालते हैं तो चांसेस ऑफ ट्रॉमा आर देयर, देयर चांसेस ऑफ इंजरी आर देयर, चोट लग सकती है, लैरिंग्स, हाइपोफैरिंग्स, ट्रकिया, इन्फेक्शन. हम जब भी कोई चीज बाहर से अंदर, अंदर से बाहर से अंदर इंसर्ट करते हैं, इन्फेक्शन के चांसेस बढ़ सकते हैं. ईज ऑफ एप्लीकेशन, अगर पेशेंट इज अप्रोप्रिएटली सेलेक्टेड, अगर पेशेंट एनआईवी के लिए सूटेबल है, फिट है, then it is very easy to apply and very easy to have good results with the help of non-invasive ventilation. Again, what are different advantages? Intermittent application, आपको लगातार उसको वेंटिलेटर पे रखने की जरूरत नहीं पड़ती है, आप बीच बीच में मास्क हटा सकते हैं. कैन बी यूज फॉर नॉन आईसीयू सेटिंग्स, आईसीयू के अंदर भी नहीं, आईसीयू के बाहर वार्ड्स में भी अगर ट्रेन्ड नर्सिंग स्टाफ हो तो दिस कैन बी यूज्ड इन दी वार्ड्स, इन दी जनरल वार्ड्स, इन दी रूम्स, प्राइवेट रूम्स एज वेल. इट इम्प्रूव पेशेंट कंफर्ट, जब भी पेशेंट को थोड़ा सा डिस्ट्रेस लगता है, ही कैन यूज द मास्क. घर पे भी इसको हम यूज कर सकते हैं. एंड जैसे ही पेशेंट बेटर फील करता है, वी कैन रिमूव द मास्क. दैट इज व्हाई इंटरमिटेंट एप्लीकेशन रिड्यूसेस द नीड फॉर सेडेशन. अगर पेशेंट को वेंटिलेटर पे रखते हैं, इन्वेजिव वेंटिलेशन पे अगर हम ट्यूब डाल के रखते हैं, तो अगर जरा सा पेशेंट आउट आता है तो हमको सेडेट करना जरूरी है. अदरवाइज देयर कैन बी बैरोट्रॉमा, वॉल्यूट्रॉमा, which can result in the pneumothorax of the patient as well as ventilator asynchrony. So therefore हमको sedate करना पड़ता है ऐसे पेशेंट्स को. अगर पेशेंट नॉन इन्वेजिव वेंटिलेशन पे है, बाईपैप पे है, सीपैप पे है, तो सेडेशन की नीड कम हो जाती है. ओरल पेडेंसी, इट प्रिजर्व्स द स्पीच, swallowing and cough. As we are not introducing anything inside the mouth, तो आदमी बोल भी सकता है, सोलो भी कर सकता है, खांसी भी कर सकता है और बीच बीच में निकाल भी सकता है. They can also eat while removing the BiPAP machines. Now, non-invasive positive pressure ventilation, as it is shown, different type of mask होते हैं. These are known as interfaces. One is the oronasal, that covers the nose as well as the mouth. Second picture, this one shows the nasal mask, and this is just covering the nose. Advantages, I will just discuss it later. इसमें advantage mostly ये है कि patient को mask के साथ भी आप feed कर सकते हैं. इस mask के साथ normally we avoid feeding below, above and before and after 2 hours because there is risk of certain aspiration. Then these are different interfaces. This is the normal helmet, this is the nasal mask, this is the oronasal mask, this is the shield, and this is the helmet. So these are the different nasal interfaces. This becomes quite easy if the patient is able to use nasal air interfaces, and however it cannot be used अगर patient mouth से breathe करता है. Obstructive sleep apnea के patients हैं जो normally mouth से ही breathe करते हैं, उसमें oronasal air interface is the better choice. तो nasal mask में क्या है? Best suited for more cooperative patients, better in patients of low severity, जिसमें severity इतनी कम नहीं, इतनी ज्यादा नहीं है, उसमें यूज कर सकते हैं. एडवांटेजेस क्या है? क्लॉस्ट्रोफोबिया नहीं होता है क्योंकि छोटी सी डिवाइस होती है, सिर्फ नाक को कवर करती है. इट अलाउज स्पीकिंग, ड्रिंकिंग, कफिंग, सेक्रीशन क्लियरेंस, आप सक्शन भी आसानी से कर सकते हो. लेस एस्पिरेशन रिस्क, क्योंकि चांसेस ऑफ वॉमिटिंग, एस्पिरेशन इज लेस. जनरली वेल टॉलरेटेड, बट हाउएवर डिसएडवांटेजेस आर आल्सो देयर बिकॉज लीक ज्यादा होता है और ओरल ब्रीदर्स के लिए, माउथ ब्रीदर्स के लिए इट इज नॉट वेरी इफेक्टिव. और नेजल डिफॉर्मिटीज में आप यूज नहीं कर सकते. उसमें नॉर्मली जो मास्क होते हैं, हम लोग उसमें क्या देखना है हमको, जहां जहां भी प्रेशर आता है मास्क का, वहां पे प्रेशर सोर्स डेवलप हो सकते हैं, रैशेस हो सकते हैं. सो देयरफॉर देयर शुड बी अ डबल फोम कुशन, एंड कुशन का भी अलग अलग मटेरियल्स होते हैं. एंड इट इज बेटर यू पॉली लाइक अ सिलिकॉन फोम मटेरियल्स, एंड इसमें देयर इज अ वाल्व, देयर इज अ प्रेशर पिक ऑफ वाल्व. अगर एक बार प्रेशर बढ़ जाता है तो ये वाल्व खुल के एक्स्ट्रा एयर बाहर निकाल सकता है. इट प्रिवेंट्स द बैरोट्रॉमा. Then other total mask का होता है, there is an expiratory valve for a portable support. अगर इसी मास्क को हम लोग नॉन इन्वेजिव के लिए यूज करते हैं ऑन दी वेंटिलेटर्स हैविंग नॉन इन्वेजिव वेंटिलेशन, उसमें हमको ये जो एयरपोर्ट्स होते हैं उनको सील करना पड़ता है ताकि लीकेज ना हो. Then what is the orofacial mask? जैसे मैंने आपको फोटो दिखाई थी. It is best suited for less cooperative patients, जो थोड़ा कम कोऑपरेट कर रहे हैं, जिनकी डिसीज की सिवियरिटी ज्यादा है, जिनको ज्यादा प्रेशर चाहिए, या जो ज्यादा माउथ ब्रीदर्स हैं, इडेंटुलस पेशेंट्स हैं, उसमें नॉर्मली ओरल मास्क का यूज. एंड ओरोफेशियल मास्क जो हैं, उसके डिसएडवांटेजेस कुछ ऐसे हैं कि क्लॉस्ट्रोफोबिया ज्यादा होता है, इट डज नॉट अलाउ स्पीकिंग एंड कफिंग, एंड रिस्क ऑफ एस्पिरेशन एंड एमएसएस आल्सो इज मोर. These are certain helmets which are used in certain facilities. It has again advantages, disadvantages. The patient is free, then the oral and the nasal cavity is free from any pressure. The whole the oral cavity, the head region is covered with the full oxygen area, and in this patient can easily have something outside the port from with the help of helmet as well. So अगर हम कंपेयर करें जो हम लोग सबसे ज्यादा यूज करते हैं दैट इज द ओरोनेजल मास्क. उसके बाद द सेकंड मोस्ट कॉमनली यूज आर द नेजल मास्क. कंफर्ट अगेन नेजल में थोड़ा ज्यादा है. क्लॉस्ट्रोफोबिया इज मोर इन ओरोनेजल. रीब्रीदिंग ओरोनेजल ज्यादा करता है. परमिट्स एक्सपेक्टोरेशन नेजल में आप आराम से बाहर अपना कफ निकाल सकते हैं. स्पीच अगेन नेजल. सो इन शॉर्ट जिन पेशेंट्स को डिसीज की सिवियरिटी कम है, जो ओरल ब्रीदर्स नहीं है, उसमें वी कैन गो फॉर अ नेजल मास्क. अदरवाइज वी कैन गो फॉर अ ओरोनेजल मास्क व्हिच इज मोस्ट कॉमनली यूज्ड. Now, what is the patient inclusion criteria? सबसे पहले patient should be alert, patient should be able to swallow, patient should be able to communicate. Sometimes if the patient is not able to communicate, but still if the patient is able to swallow and the GCS is on above borderline more than 8 to 10, then we can again select the patient for non-invasive ventilation. Essential component, patient should not be very agitated, comatose नहीं होना चाहिए. Dyspnea, again moderate to severe but short of respiratory failure. टेकिपनिया है अगर तो हम लोग यूज कर सकते हैं. इंक्रीज वर्क ऑफ ब्रीदिंग. जब भी पेशेंट हमारे आईसीयू में, इमरजेंसी में या वार्ड में कभी हम पेशेंट देखते हैं, नर्सेज जब बेड साइड देखती हैं, वो भागते हुए आते हैं डॉक्टर्स के पास कि सर पेशेंट को सांस लेने में दिक्कत हो रही है. तो जैसे मैंने बताया, इट कैन बी वी कैन गो फॉर एन एबीजी, अर्जेंट एबीजी, एंड एबीजी पे वी कैन सेलेक्ट दैट इट इज अ हाइपोक्सेमिक फेलियर और हाइपरकैप्निक फेलियर. हम लोग सीपैप मोड या बाइपैप मोड पे पेशेंट को डाल सकते हैं अगर पेशेंट अलर्ट है, और इफ द पेशेंट इज अनकॉन्शियस, कोमाटोज है, तो वी कैन डायरेक्टली गो फॉर अ इन्वेसिव वेंटिलेशन. वर्क ऑफ ब्रीदिंग ज्यादा है, एक्सेसरी मसल्स यूज कर रहा है, पर्स्ड ब्रीदिंग है, हाइपरकैप्निक रेस्पिरेटरी एसिडोसिस है, पीएच बताया जिसमें एवीजी, हाइपोक्सीमिया है. So in these patients, it is better to use give a trial of a non-invasive ventilation first and then go for a invasive ventilation if the patient is not responding. Then what is the selection criteria? This is just a like list in which we can have some things which are there in the patient. On the basis of this, we can select the patient for NIV. Respiratory distress, as I told you, with dyspnea, सांस more than 24, 26 से ज्यादा चल रही हो, where the borderline is more than 24. Use of accessory muscles. Accessory muscles मतलब chest का rise होना, neck की muscles फुलाना, नाक फुलाना. Abdominal paradox. Abdominal paradox as such कि पहले पेट फूल रहा है, उसके बाद छाती फूल रही है. Then respiratory rate more than 24 and ABG is less than 7.35 and PCO2 more than 45. So we can go for this acute respiratory failure indication for NIV. Then chronic respiratory failure. कुछ पेशेंट जो COPD के पेशेंट्स होते हैं, वो acute exacerbation में आते हैं कई बार, या फिर कई बार obstructive sleep apnea में आते हैं. उनके सिम्टम्स अगर हम जानते हैं, पूछते हैं कि दिन में अगर सुबह उठते हैं, ज्यादा फटीग होना, थकान होना, ज्यादा नींद आना दिन के टाइम पे, बैठे बैठे सो जाना, सांस लेने में दिक्कत आना, या फिर तेज सांस लेना, या सोते समय स्नोरिंग करना. तो ये सब चीजें हैं जो क्रॉनिक ऑब्स्ट्रक्टिव डिसीज में आती हैं. एंड अगेन उनमें भी हम लोग एबीजी करा सकते हैं. पीएच इज लेस देन 3.5, 7.35 and PCO2 more than 55. We can select the patients for non-invasive ventilation. Target for COPD patients, we should always keep in mind that 88 to 92% is the target. अगर हम COPD chronic patients को हम treat कर रहे हैं, तो we don't want to use high oxygen flows more than 2, 3, 4 liters of oxygen, and also we don't want to increase the saturation beyond 94-95% on high FiO2. So less FiO2 with target saturation of 88 to 92% is enough for a non-invasive ventilation for a chronic obstructive pulmonary disease patient. Then third is the thoracic or restricted diseases. Again, unme bhi symptoms: fatigue, morning headache, hypersomnolence, nightmares, enuresis, bedwetting, dyspnea, PaCO2 more than 45 and SpO2 less than 90% for more than 5 minutes. उसके बाद भी अगर हम ऑक्सीजन लगा के 10 minutes तक देख रहे हैं and the patient is not improving, if the work of breathing is more and ABG have pH less than 7.35 with PaCO2 rising or hypoxemia saturation less than 90, we can go for a non-invasive ventilation. Then what are the contraindications? ये तो हमने लगा लिया, लेकिन हमको non-invasive ventilation कब नहीं लगाना है? As I told you, coma, cardiac arrest, respiratory arrest. जब patient comatose हो, patient is not responding, तो patient will not be able to swallow. तो अगर वो swallow ही नहीं कर पाएगा, तो अगर हम मास्क लगाते हैं तो सारा secretions, जो भी gastric pressure हम बढ़ाएंगे positive pressure से, it can go into trachea and it can cause aspiration. So coma, cardiac arrest, respiratory arrest, Any condition which is requiring intubation, cardiac instabilities, GI bleeding, अगर patient bleeding के साथ आया हो, facial trauma के साथ आया हो, RTA के साथ आया हो, जिसमें patient के nasal या oral cavity से bleed कर रहा हो, then we should not use non-invasive ventilation. If there is acute obstruction, like GI obstruction is there, so that is a relative contraindication. We should not use a trial of non-invasive ventilation in that. However, it is a relative contraindication. It can be judged on the clinical basis. There is inability to protect the airway, impaired cough, swallowing, poor clearance of secretions, poor respiratory efforts, status epilepticus, लगातार इसको seizures आ रहे हो, inability to fix the interface like the burns, trauma, facial traumas, potential for upper airway obstruction like head and neck tumor ho, patient disoriented ho, angioedema, anaphylaxis, and non-availability of a trained medical personnel. Now this is added since last 2 years. Non-availability of trained medical personnel is very important. Therefore, this training of NIV usage is very important for trained nurses as well as doctors, because NIV can save a person from going into invasive ventilation and the morbidity mortality which are associated with the ventilators. Then requirements for a successful NIV support: cooperative patient who can control their airway, secretions जो निकाल सके, जिसका कफ रिफ्लेक्स ठीक हो, जो पेशेंट के साथ हम कोऑर्डिनेट कर सकें, and patient also can coordinate with the ventilator if the severity of obstruction is high, or with the CPAP machine or a home BiPAP machine if the severity is low, and patient should be hemodynamically stable. So in those patients, the success rate of NIV is very high. Then again, suitable clinical conditions for NIV. Again, COPD can be used, cardiogenic pulmonary edema, COPD exacerbation, asthma. It is very important. Wheezing हमको check करनी है. Wheezing के साथ multiple usage of nebulizations करना है. In immune compromised states, do not intubate status. If patients have given a do not intubate status or not DNR consent, then we can go for a non-invasive ventilation in the palliative as a palliative care. But however, intubation is necessary. Though if the intubation is necessary if the patient is going into a comatose condition. Then cystic fibrosis, any diseases which is respiratory as restrictive diseases, obstructive sleep apnea and the cor pulmonale. Again, it is the first indication for using of a CPAP machine. Now, there are different modes of ventilation: volume ventilator and pressure. It is a pressure controlled mode. These different modes are CPAP mode. Mostly it is used for obstructive sleep apnea and cardiogenic pulmonary edema. Then comes the S mode, as the name suggests, spontaneous mode. This mode helps in better synchrony with the ventilator, and the patient is conscious and patient is having a good synchrony with the machine. Then there is ST mode, in which we have to give a certain amount of respiratory rate, or a trigger mode should be used in those patients with acute respiratory failure or cerebral hyperventilation. So in that, ST mode can be used, and T mode is rarely used. If we are going to use a T mode for a longer time, it is better to use an invasive ventilation rather than relying on a T mode, because T mode means the patient is not very cooperative, not managing the or not being manageable on the NIV or non-invasive ventilation. Then there's some other mode like PAC mode and the IVAPS mode. Again, it is a type of a non-invasive ventilation, and it can be used for weaning purposes from non-invasive machines. Again, as another more controlled, as the control mode is T mode, similar to pressure control ventilation. Assist mode is S mode, similar to pressure support ventilation. And assist control mode is the ST mode or the spontaneous mode, also same as the pressure support ventilation. Now, coming to two main aspects. Just a minute. Two major aspects. One is the CPAP. So now what is the CPAP? A constant pressure is applied. CPAP means a continuous positive airway pressure. In this, a minimum amount of pressure of a PEEP is given during the whole cycle of during the whole machinery use. So it is mostly used for obstructive sleep apnea patient or less severe type of obstructive sleep apnea or respiratory distress patients. It is not a ventilatory mode. It is just used to correct the hypoxemia, that is a type 1 respiratory failure. Airway pressure is normally uses 5 to 10 centimeter of H2. That is the normal PEEP. Normal PEEP which we require for the alveolar opening is 5 centimeter of H2O after we exhale, and it helps to keep the alveoli. It increases the intra-alveolar, intra-bronchial pressure, as all the NIV machines does. It recruits the alveoli. Recruitment decreases the pulmonary edema, increases the functional respiratory capacity, and decreases the work of breathing. Most patients who are provided non-invasive on the CPAP mode are beneficial from cardiogenic pulmonary edema, congestive heart failure, and obstructive sleep apnea. Then this is a normal pressure volume mode. However, it is not very well experimented here, explained here. Then other mode is the BiPAP mode, which is we commonly use, and this should be known to every nurse, every doctor in ICU, in emergencies, even in wards, so that we can prevent the patient landing up into invasive ventilation. As the name suggests, BiPAP, it is a bi-level positive airway pressure. In this, we have two pressures, in short, IPAP and the EPAP. IPAP is the pressure which we have to give to the patient during the inspiration, minimum amount of pressure, and the EPAP is the expiratory positive airway pressure. That is the minimum amount of PEEP in the language, in a simple language, which should be there to prevent the closing of the alveoli. Now difference between the IPAP and the EPAP is the pressure support, and addition of IPAP is the EPAP is the total inspiratory positive airway pressure. Now, BiPAP again, what it does, it lowers the positive airway during expiration, higher positive airways during inspiration, and this two pressure mode helps to increase in the even in the hypoxemic failure, even as in the hypercapnic failure, it can be used both ways. And now, when we are using BiPAP, a simple short notice for everyone is that जो भी नर्सेज को यूज कर रही हो, अगर वो जब भी हम एबीजी करते हैं, for all the new colleagues of mine who are just joining the ICU or ED and who are practicing there, we have to see the ABG. If we want to increase the carbon dioxide metabolizing rate or the excretion rate, then we have to increase the IPAP. If we want to increase the hypoxemia, treat the hypoxemia, increase the oxygenation, then we have to increase the EPAP. Minimum difference between the IPAP and the EPAP should be around 4 centimeter of H2O. Like a basic setting can be a 10 to 6 or 5 to 9 settings. It should be 4 to 6 centimeter of H2O for better patient synchrony and with the ventilator, as well as for patient landing up into less chances of atelectasis. Now, what is the backup rate? एक backup rate भी होता है, target patient rate होता है, which we have to set up on the machines, and it should be like normal breathing rate is 14 to 18 per minute. If the patient is breathing more than 24, so we can keep target breathing rate around 3 to 4 breaths less than the target rate, like 16 to 18. However, if the major chunk which will be done, जो major चीज जो इस चीज को गाइड करेंगी, वो आपका IPAP प्रेशर और EPAP प्रेशर होगा. अगर अगेन वही, अगर आपको CO2 वॉश आउट करनी है तो आपको IPAP बढ़ाना है, अगर आपको ऑक्सीजनेशन इंप्रूव करनी है तो आपको EPAP बढ़ाना है. Then again, what predictors of successful, agar patient ki synchrony with the ventilator is good, patient consciousness has been regained, patient is responding well to commands, patient is improving clinical wise, then we can say that the trial of a non-invasive ventilation is useful. However, this trial there is no certain time limit. However, 30 minutes trial should be given before going on to a decision of an invasive ventilation if the condition permits. अगर पेशेंट आपको परमिशन देता है कि उस टाइम तक कुछ टाइम तक आप उसको वॉच आउट कर सकते हो अंडर क्लोज ऑब्जर्वेशन, so you can go for a non-invasive ventilation, and we should go for a non-invasive ventilation trial for at least 1 to 2 hours before going to the decision of a invasive ventilation. ABG आपको एवरी आवर्ली करनी है अगर पेशेंट सीरियस है एंड हमने उसको नॉन इन्वेजिव मोड पे जस्ट फॉर ट्रायल पर्पस पे डाला है. अगर उसका ऑक्सीजनेशन इंप्रूव कर रहा है, PCO2 इंप्रूव कर रहा है, पेशेंट रिस्पॉन्ड करना शुरू कर रहा है, दैट मींस कॉन्शियसनेस रिगेन हो रही है, देन दैट मींस द पेशेंट इज responding well to non-invasive ventilation. If not, directly go for an invasive ventilation to save the patient's life. Now, what is the predictor of success? Again, decrease in the PCO2 more than 8 millimeter Hg in 1 to 2 hours. Improvement in pH more than 0.06, correction of respiratory acidosis, decreased work of breathing, and more comfortable patient. फेलियर टू NIV, ये तो हमने देख लिया कि पेशेंट सक्सेसफुल कब हो रहा है NIV पे. फेलियर कब होता है? नो इंप्रूवमेंट इन गैस एक्सचेंज और डिस्निया, deterioration or no change in the mental condition of the hypercapnic patients, need for airway protection, hemodynamic instability, अगर कोई MI, arrhythmia, cardiac instability हो रही है या patient is unable to tolerate the mask और work of breathing बढ़ रही है, then it is we have to go for a decision of intubating the patient after consent. Now, what are the complications? It can be both with non-invasive as well as invasive. However, with non-invasive, there can be facial and nasal pressure injuries. Pressure sores बन जाते हैं, rashes हो जाते हैं, pressure sores on the cheeks, nasal cavities, chins. Therefore, protection of these area with the like gentle borders or some soft jellies or some cotton pads is very useful and should be used. Schedule breaks intermittently, आपको उसको 1 से 1.5 घंटे के बीच में यूज करने के बाद आपको 10 मिनट के 15 मिनट के लिए you have to minimize the interval of NIV to prevent the pressure injuries, and also strap attention. ES पे pressure नहीं आना चाहिए, ES पे tearing नहीं होनी चाहिए, so we have to keep in mind. Gastric distension is another complication. Dry mucous membrane, because we are giving airway pressures. Therefore, it is now जो हमारे पास नए ventilators आ रहे हैं वो humidified oxygen को हम लोग use करते हैं. So therefore, this dry mucous membrane and thick secretions जो बन जाते हैं, उसको भी time to time हमको with suction हमको इसको improve करना है. Aspiration of gastric content. If the patient is not able to swallow, ठीक से swallow नहीं कर पा रहा है, तो aspirate कर सकता है on the non-invasive ventilation, because the oral airway or the oronasal cavity is still exposed to the aspirate of the gastric contents. Now complication of both non-invasive and invasive, barotrauma and hypotension. हम लोग जब pressure ज़्यादा pressure देते हैं, more than 20 centimeter of H2 of IPAP use कर रहे हैं, या फिर EPAP भी हम लोग more than 10 centimeter दे रहे हैं, तो due to more pressure, venous return is decreased, and therefore it can lead to hypotension, BP गिर सकता है, and barotrauma as well. What are complications which are avoided by non-invasive? Ventilator associated pneumonia, sinusitis, traumas, later complications of ventilator dependency of the patients, morbidity, mortality of the patients on ventilator, sinusitis, as well as the use of sedative drugs is more on the invasive ventilation. So these all complications can be avoided by a non-invasive monitored ventilation. Now, what is the protocol? Patient selection is critical. Patient हमने select किया, appropriate, हमने उसको 30 degree पे हमने head raise किया, select and fit the interface depending on the patient, nasal interface, oronasal interface, select the ventilator mode. Either you can go for a CPAP, home BiPAP machine, or a ventilator mode if the patient is in ICU. Apply the headgear, avoid excessive strap tension. Again, connect the interface and prevent any leaks. Check करो कोई leak है कि नहीं. Start with low pressure, 8 to 12 centimeter of H2O inspiratory pressure, and 3 to 5 centimeters. Like I suppose we always start with around 10 and 6 support of 10, 6 or 8, 4 support. We always start the BiPAP. Gradually increase the inspiratory pressure if the patient is not improving. Up to 20 you can improve every 10-15 minutes to see the patient dyspnea improve हो रहा है, work of breathing improve हो रही है, tidal volume increase हो रही है, consciousness improve कर रहा है कि नहीं. Oxygen supplementation can be given in some BiPAP or CPAP machines. There is a port for oxygen. तो अगर हम घर पे use कर रहे हैं तो we can have an oxygen concentrator. उसमें हम लोग we can use that this port for extra oxygen if we need to keep the saturation around 88 to 92. Check for air leaks, humidifier. For always use filters. Mild sedation can be used, but not deep sedation, because again deep sedation is a contraindication for a non-invasive ventilation. Now, how to wean? एक बार हमने use कर लिया, अब हमको wean भी करना, जैसे हम ventilator से wean करते हैं, we also have to wean the patient from the BiPAP, and for this again we have serial ABGs. हम लोग ABGs करके देख सकते हैं, हम लोग patient के clinically patient को assess कर सकते हैं. उस साथ साथ we can directly from continuous positive airway pressure, now we can use intermittent BiPAP, decreasing the frequency of BiPAP machine usage, and then keeping the patient on the oxygen therapies. And if the patient is able to survive on the oxygen therapies, or unable to respond on oxygen therapies, we can wean the patient from BiPAP. So slowly titrate the IPAP, then trial of NPPV is given. We should always keep in mind a rough limit. If the patient is doing well on a pressure support or a inspiratory pressure of 10 with a minimum PEEP of 5, then that is the and FiO2 of 40 to 50, less than 50, then we can say that the patient is weanable from the non-invasive mode of ventilation and can be put on supplemental oxygen. Now this is just a flow chart. Again, the patient selection, as I have told you, after patient selection, initiation of how to initiate the therapy, then when to take the patient on ventilator, when we have to choose the fittings and the initial settings, and what are the favorable diagnoses, which can be all are covered in the whole lecture. And this is just a crux of the whole lecture. And how to select the patient, what is the equipment selection, what is the mask which should be used, what is the criteria for using the non-invasive ventilation, hypoxemic respiratory failure, hypercapnic respiratory failure, then increasing the IPAP in hypercapnic respiratory failure type 2, increasing the EPAP in type 1 respiratory failure, then weaning the patient from these, decreasing the IPAP, then decreasing the EPAP, and then weaning the patient from the non-invasive mode of ventilation. Then this is again the adaptation and the weaning mode, which is explained in the crux as a summary. So now this is all the documentation which we should have if the patient is kept on non-invasive ventilation. कब डाला, क्यों डाला, कैसे डाला, और उसके बाद what is the response of the patient, assessment of the patient every hourly or 2 hourly, and after 1 hour or 2 hours, if the NIV is successful, then we can label the patient as successful on an NIV. We can continue the NIV, or we can take the patient on the invasive mode of ventilation if the patient is not responding. Thank you.
Thank you, Dr. Shashank. Very nice
Thank you, sir.
presentation. Am I audible?
Yes, sir. Yes, sir.
Very nice presentation.
Thank you so much.
Any question from audience side?
If there are any questions, sir and me are here, so we can answer those. अगर आप कुछ भी हो आप पूछ सकते हैं. All the nursing staff, if you want any help.
So okay, that's okay. So I think है ना for the take home message for the nursing staff कि first of all patient compliance is very necessary for to keep a successful NIV ventilation for any patient. And second thing is that the proper monitoring should be there whenever any patient taken for NIV ventilation. Nursing staff to do a proper monitoring. They can anytime land up in an invasive ventilation. Okay, Dr. Shashank, thank you.
Thank you, sir. Thank you so much, sir. Thank you, everyone. Thank you, sir.